All right, on today's edition of the Provider Engagement Podcast, we are very excited to have Ryan Dodson with us. Ryan has a long history working in health plans around risk adjustment, provider engagement, quality, and stars. And not too long ago, actually went into founding his own company with some partners to provide provider education and do some of the other services around value-based care and the traditional things like chart retrievals and record chasing and those things. But it is going that step beyond to provide provider education that really sets Ryan and his company apart. So Ryan, thank you for being with us today.
Thank you for having me.
So Ryan, let's jump right into that and kind of get some of that background, because you've had this long history and career in provider engagement and doing coding and managing coding teams and doing that on the health plan side. But what were some of the big things that led this shift and now going in and having your own company to do the consulting and do some of this own work? Like, what were some of the gaps in the industry that you saw could be serviced?
Well, when I look at the industry across the board, like everybody does provider, they have analytics, they have chart chases. You have big chart chase companies who go out and collect that data and do the retrospective reviews, and even they do some prospective reviews. But what I noticed in the industry was that there wasn't really a thing that actually delivered that back to the provider. Yes, you have analytic tools that deliver it back to the provider, but you never had that, that kind of that one-on-one working with the provider. And so that's what I wanted to get into, was I wanted to fill that void area where you actually go out and talk to the provider and you help them improve their documentation. And yes, you might be hired from one group to do it, but really you're trying to help the physician. So basically be like a physician, advocate, trying to help them improve their documentation across the board. And if you can get them to improve on one set of patients, they're going to improve their documentation across everybody. So like when I go in and I talk to doctors, I'm like, hey, I'm here to teach you on this, your Medicare Advantage members, but I would like you to start doing this documentation on your commercial members because, knock on wood, hopefully they age into Medicare Advantage, your Medi-Cal membership or Medicaid membership. I said, that's something you should document on, because all those lines of business risk adjust just a little bit differently. So, but if you can teach them proper documentation, it will improve their documentation and their scores.
From your perspective, like being there in the front lines and kind of down in the trenches, like what are some of the biggest, not necessarily obstacles, but some of the biggest mistakes or things that are lacking in terms of documentation? Like, where is most of that education or most of the opportunity for improvement happening from your perspective?
Well, providers come from a fee-for-service world, so they're doing quantity over quality. So they're trying to get 25, 35 patients in a day, and they're not taking the time to document all the things. They're taking care of the patient, but they're just focused on what they're there for. So usually during your annual wellness visit, that's when they capture all the diagnoses. But you need to show the provider how to document more correctly and according to guidelines, and making sure that they capture it. Now the physician is a physician, so if you give him you show them how to document and they don't agree with it, by all means, they don't agree with it, it's not something they should document. But like if I go into an office and I tell a doctor, like, hey, this patient has diabetes and you documented renal insufficiency, but if we look at the labs, their EGFR is 27 for the last 9 months. That's not really renal insufficiency per se. I mean, you need to document that more specifically. That's CKD stage 4. And then I asked the doctor, do you believe that the diabetes is related to the CKD stage 4? If so, you want to document diabetic chronic kidney disease stage 4. And the way that works in risk adjustment is diabetes without complications is a 0.105. So that's what they had been documenting. But diabetes with a CKD stage 4 is a 0.302 for the diabetic complications, plus a 0.289 for the CKD stage 4. So now you're looking at you're above a 0.6 on just those two diagnoses. So you've increased your documentation and your RAF score by almost 600% right there. Now, it doesn't affect the way the doctor treats the patient, but it's just being more specific in their diagnosis and their documentation will help them and the health plan.
Oftentimes there is that gap, like say, does it really change the way the doctor treats the patient? But it's just affecting the RAF score. And is that just this thing that's there for administration or like bureaucracy and CMS or other things like that, or does it have an impact somewhere maybe in the broader scope of that patient's healthcare for it to be documented that way?
Well, RAF score is what sets the resources for the patient. So, the higher your RAF score is, the more reimbursement you get, which makes you have more money for resources to take care of the member. Because, that HCC or risk adjustment money capitation is what pays for your case management. It what pays for your specialists if they're capitated. It pays for the different programs for the patient. And if your RAF score isn't correct, might not have that extra money for the health education department. You might not have that money for that proactive case management to keep them healthier and keep them out of the hospital.
So how do you see that connection of you as an expert in the area, breaching that gap between this mindset of fee-for-service versus value-based care?
Really working with doctors, and like I've trained thousands of doctors over my career in risk adjustment. It's really about, getting in there and showing them that you're there to help. And really just saying, hey, I'm here to help you. I'm not here to make your job harder. I'm here to make it easier and document more correctly so the members get better care. And the hardest part of HCCs is the first year. If you go into a fee-for-service doctor and you work with them on their charts and you help them improve their documentation or just help them clean up their problem list. You know how many doctors I've cleaned up their problem list because there's all these things that the patient doesn't have anymore. That's just there or is incorrect. And so we clean it up and we clean that out and we make sure that everything's documented correctly. And now the next time they see the members, they're able to go over those. And if you get all of your HCCs done in the first year, now the next year it's just reevaluating that and making sure there's nothing new that pops up. And now you're better care for your members. And then I tell doctors, they're like, well, I don't have time to capture all these. I'm like, listen, what I suggest is the first visit of the year, do an annual wellness visit, try to capture everything. I say capture as much as you can in that visit. Make it a 30, 45-minute visit. Get everything captured out of the way. Now the next time the member comes in, say they have a cold or something, you're just focusing on that cold and anything else that would affect that patient's care that day. But you have all the HCCs captured in the first visit, and now you're taking care of. Now you can focus on your quality measures or your HEDIS measures and get those captured also.
Providers need to deal with multiple health plans throwing this information, and how, when they don't have a teams of educators like yourself, how do you see them trying to get these multiple sources of data, of reporting, being centralized into what you believe would be a good coding or a good experience when it comes to closing gaps in care? How do you see that?
One of the biggest issues I see is that health plan data can be anywhere from 60 to 90 to 120 days behind. So you really have to work with the IPA or the MSO that manages that provider group to give them information, because a group might be, a provider might be contracted with 6 or 7 health plans and then 4 or 5 IPAs. I guarantee you 99% of the time, every one of them is going to have a different system. So you're having your staff log into 5 to 10 different systems. It gets to be burdensome, and they can't do it. So, but if you work closely with your IPA or your MSO who manages that provider population, then now you can get one single date of service. So an IPA can take all of the health plan data from 7 different health plans and then give that down to break it down into one, data feed. And so it's not like, okay, Will's my doctor, and I come and say, hey, here's your health plan reports from 7 different plans. I'm like, hey, Dr. Will, here's your gaps in care and your missed chronic conditions on your population. And it shouldn't matter who the health plan is. It should just matter on making sure those chronic conditions and those gaps in cares are closed at the point of care.
How do you envision companies like yourself or the health plans tailoring that education for specific areas of that particular solo provider that, that they want to make sure that they don't repeat the same per se problem when it comes to closing gaps in care. So how do you see that? How do you envision that? You were like dealing with that specific from the provider side. How you be help?
So what we do is we get the data from the health plan, and we also get a data from a chart review. So when we do a chart review, not only are we doing like a retrospective review to submit codes that have been that are captured and should be submitted to the plan, we're looking at where the doctors can improve their documentation. And then we take it back and we tailor an education to the doctor based on their own charts. So like I could come to you and say, Dr. John, I reviewed your 200-member panel in your chart review. Now let's look at Will's chart. Let me show you in Will's chart where I think you can improve your documentation. And then it's a dialogue, because a provider is not going to agree with you all the time. But most of the time, the doctor's like, well, I didn't know that. It's like I was working with a doctor one time, and in his past medical history or review of systems, he wrote in the thing like patients here for this, and this, and then patient still attends AA meetings twice a month. And so to me, as a coder and a CDI, I'm like, I'll go to the doctor. I'm like, hey, he attends AA meetings twice a month. I'm like, did he used to be alcoholic? And they're like, yeah, he was. He's in recovery. And I was like, okay. I said, what you want to make sure you're documenting is that alcohol dependence in full remission. I said, because that's a diagnosis code, and that is an HCC, and that's going to give us resources in case something happens and this patient were happen to relapse or something. We have that information ready for them, and just showing doctors that in their own charts how to do, because I have programs which are an overview of training, but if you can actually go down and show them in their own notes where they can improve, it's like a light bulb goes off, and they're like, oh wow, I didn't know that.
What are they really having to put into making sure that all this documentation is in place to meet those reporting requirements?
Well, so one of the funny things about me is I wasn't always in this industry. That's why you'll hear me like mispronounce things or stutter. So I have an operations background. So I used to work at the busiest airport in the world and run the ground operations for an airline. And so what I can do is I actually go into the offices and I look for choke points that is slowing an office down in their documentation. So you figure, what you would need to do a proper program is you need to have, it's the whole team. And so when we go in and we do education, not only do we educate the provider, but we make sure that because usually our educations are at lunch, and we bring in lunch for the whole staff. And then we have the whole staff sitting in on the training, and we tell them like, hey, this is a team effort. I'm like, your front office staff is going to be the person who schedules the patient, make sure it gets in. They're going to be the person that logs into that system. Them or that MA is going to log into that system and get the doctor his information for that patient. I said, and one of the biggest things with quality right now is customer service. And that's the whole office staff. If you have a bad experience when you first walk in with the receptionist looking down and just typing and not paying attention, then that's going to set the tone for your whole visit. But then you go to from the MA getting the stuff to the doctor documenting it, and then because a lot of the HEDIS and quality stuff and the screenings and stuff, those can be done by the MA staff. The provider is the one that has to document and sign off on it. And then on the back end, once the doctor documents everything, making sure that his billing staff submits all the codes, because that's what we found, especially in the beginning of these programs, was that offices were only submitting 4 codes. So while they might document 10 to 12 diagnoses, only 4 were getting on the claim. And none of the CPT2 codes were ever getting on the claim. So it looked like the patient never had a BMI, or the patient never had their blood pressure checked, even though it was done at every visit. So we train the staff from beginning to end. So to completely run a program, at a minimum, you're going to need 3 to 4 staff to do it. And if the MA and the front desk are the same, you can get away with 3, but the biller and the MA aren't going to be the same person. So you need the front office staff, you need the medical assistant, you need the doctor, and then at the end, you need the biller.
What is your philosophy on how to make incentives more effective? And what what is a good incentive?
So you have to start with the whole office. It can't just be the provider, because the other staff is going to be doing work too. So what we do is we set up an incentive program that pays them for quality over quantity. So when we do an incentive program, no matter if you're at the health plan level or you're at the MSO level, getting at the MSO or IPA level is much better than health plan, because you can't really affect it by the time they turn into the plan. So, we make sure we incentivize that front office staff to make sure that they're calling the patients, scheduling them, making sure the doctor gets the information in front of them, making sure that the patient comes in. That's an incentive for the office staff. The provider gets their incentive based on documentation. That documentation needs to be audited. I always tell people, like, when you start an annual wellness program, you're going to be able to notice patterns in what they turn in. And if you notice a pattern, you can go back and train them. Educating a physician on risk adjustment when they've never done this before is like training a new puppy, or better than that, training a new husband. And I've been in training for 17 years. So I know, it takes a reinforcement of, hey, you shouldn't do that. Or, hey, you need to do this better. And if you go back and you do it, like by the second or third time they've seen you and you're giving them the mistake, they stop making that mistake. Just like when you pick up your puppy and say, hey, don't go here, let's go outside. That's how you're doing that positive reinforcement. And so, and the other thing is making sure that you really have a good relationship with that front office staff or that office manager, because they're the gatekeeper to the office. If you can't get a good relationship with them, you're not going to see the doctor, period. So, I always say, hey, come in. At one of the first groups I ever worked for, I used to have an Excel spreadsheet on my computer that told me, the pertinent information for the offices. And then I had a couple columns that were like, people were like, where did this column come from? And basically it was best time to go by and visit them. And then it would have their Starbucks order in the next column. And they're like, well, why do you bring Starbucks? And I was like, I'm coming to ask them to do some work. I'm not coming empty-handed. I always tell people who are like, well, I can't get into an office, they won't let me in. And I'm like, show up with donuts and coffee. I'm like, you'll get into any office you want to if you show up with donuts and coffee. I actually had a product that I did like 5 years ago in Phoenix. And I was a consultant, and they're like, we can't get in this office. So I went to Dunkin' Donuts, and I got 2 dozen donuts and 2 gallons of coffee. And I went in and visited the office. And they brought me in the back. They sat me down. I talked to the office manager for a little bit, talked to the doctor, got everything taken care of. I went back and visited that office a couple years later when I was driving through, and I was like, hey, I just wanted to stop by and say hi. I was here a couple years ago. They're like, yeah, you're the guy that brought us donuts and coffee. He's like, nobody does that.
Sometimes it's the simple things, right?
Yep. And that simple, $20, $25 investment, now you just open the door to the office. And now you can get them to do what you need them to do.
Good.
And then structure your incentives to where they're paid out at meaningful times. So the first incentive that we ever created, we did it to where, we paid the doctor to do an annual wellness visit. And that was paid out quarterly. So that he knew, hey, you turned in 100 last month, here's a check for $7,500 because you got paid $75 a visit. And then the office manager incentive, we pay that out the week before Thanksgiving. And people are like, oh, I'm like, no, there's a method for my madness. I'm like, what comes after Thanksgiving? And they're like, what? I'm like, Black Friday. So if this office has been working all along, and then you deliver them a check for like $3,000 or $4,000 the week before they have to go Christmas shopping, you just made their day. And then guess whose program starts #1 next year?
All of these transactions that are happening, all these interactions, they're human beings, and we all, go to work, and we all see, the patients or do our tasks, and then we all, go home, and we all lay our head down at night, and we wake up and do these things over again. But everybody's bringing their own experiences. Everybody's bringing their own worries and concerns and other things to that job site today. And we have to keep that human element in mind.
And that's the biggest thing is remember that human element. You're going to go into an office, and like I've been this, like you have to learn especially if you're doing provider education, you have to learn when it's not a good time. So like I'll go into an office and like, I'll see something going on and I'll just drop my card and leave because I know it's not a good time. And it's walking away from that, bringing in lunch. If you're going to take up their lunch, bring in lunch. Don't just expect to get time with the doctor. Meetings at the very end of the day, they're not really worth it because the doctor's tired. Plus, they have to do charts. And I tell people, like, when you're doing physician education, watch their body language, watch their face. I'll tell people this all the time, and I've done training with other doctors, I've done training with RNs, other coders, and it's you can watch their face and watch when they're done. I tell people, half of my job is to be a stand-up comedian. I need to make them laugh. I need to make them remember what I want to document. Like I tell stories that aren't true, but they're funny because they make the doctors remember, like, oh, I need to document that, or I need to document this way, and then they'll remember that. But if you can get that kind of rapport with your doctors, now they're going to do it. And then the other thing is if they ask you a question that's outside your realm, still follow up on that question because now they're putting their trust in you. And once you lose the doctor's trust, it's next to impossible to get it back.
Where do you see that this technology falling short when it comes to provider education?
Well, it really depends. And I've actually worked with a few technology companies on this. How easy is it to get the report? How easy is it to get the information you need? Are you having to click through 5 different screens to get to the reporting you need? Are you able to just patient search, look up date of birth, and boom, there it pops up on the screen? Are you able to print that easily? Because, even though we do technology and it's there on the screen and most doctors are carrying around notebooks, the doctors aren't the ones used, like you said earlier, Will, the doctors aren't the ones using the system. It's usually the MA staff or the front office staff. So you're going to have to print that form out and give it to the doctor and say, hey, doc, Mrs. Smith is here today. Here's her open gaps in care, and here's her open risk adjustment diagnoses. Let's make sure we address those if they're applicable and get them documented today. That you have to have ease of use. And then integrating, if you can integrate with the EMR, that's great, but a lot of systems aren't able to do that yet. And then, realistically, it's, how the use, how easy is it to use it? Because if you have to click on 10 different things, they're going to be like, it's not worth my time.
One of the big questions that we get asked a lot is like, oh, does it integrate with the EMR? And those things are rolling out, but they're hundreds. We asked, I think somebody from one of the Blues at one of the conferences, what do they do about independent providers? And they're like, oh, I've got 120 plus different EMRs that we're dealing with. Interoperability there is just not an option, right? And then even when they do, if you're in a big Epic or Athena or one of the bigger things like that, all these other integrations, they end up being, like you say, extra screens or extra tabs, or it's all this other stuff. And so is it how beneficial is it to the provider, right? It can be beneficial to the health plan to kind of be able to have that access to the data, but still then they have to go and look through 2 years of data just to find the chart that they need if there's not that open communication channel.
Right. And one of the EMR systems I like that I've seen used, basically we put a sticky note on the note. So when the doctor brings up the patient, basically a sticky note pops up on the screen and it says, hey, these are your open gaps. That's easy for the doctor. It's basically you handed them a piece of paper, but it's on their computer. But a lot of other systems, like you said, you have to go into multiple screens to get it. And it's just they're like, I'm not doing this. The incentive isn't, worth it. It's I knew a group that paid $200 for an annual wellness visit, reporting to get back. But the form that they sent the doctor to fill out was 15 pages. And I came in and there's a stack sitting on their desk. I'm like, what's that? He's like, something I ain't going to do. And I was like, no. And I was like, well, what is it? And he explained to me and I was like, wow.
How long do you think that would have taken him to do? 15 pages of going, for that one patient or whatnot, to be able to document?
Between him and his staff, I would think that documenting on that form Probably a minimum of 25 minutes a patient.
So 25, yeah. So 25, 30 minutes a patient, in there, $400 an hour when you're talking about a staff of 3, 4, 5 people, it's, that may be barely break even.
Right. And then not only do they have it on that form, but it needs to be documented in the progress note. I tell doctors all the time, they're like, well, they haven't given me this form. I'm like, doctor, at the end of the day, I'm fine with you filling out the form, whatever you want to do. I need it in the progress note, in your EMR or in your chart. Like, that's where I need it. Because at the end of the day, when it comes to validation, it's going to come from your progress note and chart. It's not going to come from this form. And it's really, it's really about engaging the providers. You have to engage the physician, engage their office, and keep them engaged. You can't, like, people are like, well, when do you start your risk adjustment program? I'm like, I started in December every year. They're like, wait a minute, why December? And I was like, they're like, the membership, you're not going to get the true new membership numbers until, open enrollment ends. You get everything, you're looking February, March, where you get the actual true membership numbers. And I was like, if you start in February or March, you just missed the whole first quarter. I'm like, usually these doctors, their members, they stay with the doctor. So you get them to document, and they start January 2nd. I had a doctor that had 285 providers, and by March, the end of March, he was done. He had done annual wellness visits on every single one of them, except for like
Wow.
2 who were like snowbirds who used to go down south because they didn't want to do it. And I said, you're really good at this. I said, why do you get this done so early? He's like, so I don't have to see you for the rest of the year. And I was like, what? He's like, I'm just kidding. He goes, I want to get it out of the way. He goes, because we'll have a couple that are hard to get in, and we'll capture them later in the year. But if I can get all these done now the next time they come in, if they're just coming in for a cold, all I got to do is worry about the cold, Ryan. I don't have to worry about, oh, did I document their diabetes? Did I document this? Because it doesn't affect the treatment at that time. And I was like, well, that's smart. I said, and you don't have to see me. I said, I'm still going to come by. He's like, yeah, I figured.
So from a summary perspective, Brian, you were to give a top 3 piece of advice to any health plan or large practice administrator, what will be those 3 from the provider education perspective? What will be those 3 pieces of advice that you say there will be a changer for your
It would
practice?
move the needle.
Yeah.
The first thing you got to have is you got to have correct data. If your data is outdated, then the doctor's going to look at it. And if your data is wrong, the doctors are going to start losing faith in it. They're going to stop looking at it. Number 2 is the physician and the whole office engagement. So you have to engage that physician and engage them often. Don't show up in October and be like, hey, you need to do this before the end of the year. Start that engagement early in the year and start by getting it done. And then the third is making sure that the correct data is getting to you in a timely fashion. So you need to audit. So like for example, if I do an annual wellness visit and there's 14 codes, not 14 HCC codes, but there's 14 things diagnosed. Plus you have your blood pressure, plus you have your BMI, plus you have functional status exam, all the things are done. Take that note, and then when the claim comes in, audit it and see what data is missing. Where's your data gap? If there's a huge data gap, that's where you need to go educate them. Because some of these members, especially the older population, can have anywhere from 15 to 30, chronic conditions. They're not all HCCs, but they're just different conditions. And you want to make sure that data is getting across. Because if you can get that data in more real time and on encounters versus having to do a retro chart review supplemental, then it goes across to the health plan much cleaner.
Well, I hope everybody has appreciated this conversation. And if you want to reach out to Ryan to learn more about what they're doing at New Vision, or reach out to us from iCare and understand how we're helping to implement a lot of these things that Ryan is talking about from the technology perspective, then our contact information will be in the show notes. And everybody, enjoy the rest of your day.